So Brian has just said to you, we have sent out some reports this year to help you understand and support your understanding of ABF. So this is the first adjustment since 2021, which was run on the 2019 data. And that's just very much a very simple model of how, how the mathematics work. So if your hospital has a DRG value of 100 million, plus you get an agency co-payment, an oncology co-payment, that totals up to an ABF value of 104 million. Now, the data you send us in terms of your costing files will tell us how much your ABF cost is. So for this hospital, there's an ABF gap of 4 million. And so with benchmarking in action this year, as Brian said, we had a 15% transition. So with an 85% transition, meaning you're exposed to 15% of the gap. So that means that the budget adjustment that was applied for this example hospital would have been 600,000, 15% of the 4 million. And next year, because we're moving to an 80% transition, they'll be exposed to 20% of that. So the adjustment would be 800,000. Actually, just one thought that came into my head there about what Stephen was saying with IFMS, and just I forgot to start with it. The data that you send us allows us to see very deeply under the bonnet of hospitals, the coding data you're sending us in, the costing data you're sending us in, but we only really see that for a year in arrears, for a full calendar year in arrears. And we have worked with Michael Asia there about putting attributes into IFMS that will help identify the service area and the service description. So, IFMS should actually be able to show, live in year, what the expenditure is on a particular sort of ward, if that ward has an attribute of ICU or physiotherapy department or labs or radiology. So it's just something that came into my head while I was listening. Brian has just put up pretty much that slide there. I suppose there are so many inputs into ABF, how much the budget is, how much of that budget you spend, how much your activity is, how that activity translates into weighted units, whether all your cases are coded, that this was an attempt to try and put all of those things into a single report and actually allow you to compare yourself against other hospitals. The important thing is that ABF is budget neutral. It is actually budget neutral now within every model. So it means hospitals are only actually affected by their peer hospitals within each model. So that's been the data that we've shared with each group. We asked that those reports be circulated onwards to each hospital. We've had some interesting meetings as follow-up with the hospitals to go through the outcomes and the outputs. So look, that's the information that's been shared. Now, I suppose this being the first adjustment we've run in quite a number of years, there used to be a kind of rhythm to ABF. We always used to see the same hospitals winning, the same hospitals receiving negative adjustments. But I have to confess that before we ran the model, I was really, really nervous because that rhythm was obviously disappearing with COVID, because there was so many changes that there was the activity had dropped significantly from hospital to hospital. All of the additional budget that has come into the system, the additional WTEs. Again, we're in Limerick. We're very aware of the amount of WTEs, the amount of new beds that have come into the system here in Limerick. Significant increases in ICU beds, which may or may not have transferred into increased complexity, and changes in ward use, that AMUs, were being used as normal wards, and some of them were slow to revert. So I was actually, pleasantly surprised when we ran the model and things were within an acceptable range of adjustment. The last thing we want is an ABF model that leaves a hospital unable to pay its staff come September. So again, it was, we have put data out there that shows, how the positions have changed from 2019 to 2022. So that is there. Now, Brian's just spoken about our external website. We do have an internal costing website. So all of this documentation is up there. So, you can see the benchmarking results in summary form, in more detailed form in terms of activity and costs. And you can see at high level, some of those inputs that have gone in the system, and how the changes from your hospital's position in 2019 on all of those inputs have changed into 2022. And that's just an example of what the opening table. That's kind of pretty much similar to my first slide that shows the mathematics. I suppose one thing we showed was the uncoded cases and the uncoded penalty estimate by hospital. So you can maybe include that in, a shadow. Look, if we had coded all of our cases, our adjustment was X. If we'd coded all of our cases, perhaps the adjustment would have been an improvement on X. And just a word on the uncoded penalty. I sometimes say internally we're kind of coming at the wrong way of saying that, because an uncoded case doesn't have a DRG. And I think I can think of previous presentations we've done at the ABF conference where we said DRGs are very much like an invoice. You code the patient gets a DRG, and that's your invoice. So an uncoded case has no DRG, so DRG drives ABF value. But I suppose despite this, we're actually imputing a value. So we're taking the value from 0 and imputing a value for those cases, up to 80% of the average weighted units, with some other factors going in to make sure we're not imputing a value for ICU for a day case, etc. So in mature ABF systems, those uncoded cases would receive no value, and we are reducing the imputed value annually, similarly to the transition adjustment. So again, this table here is just put glasses on or glasses off. So we've shown each hospital versus its own model and versus the overall ABF average. We're telling you, what are your overnight inpatient cases? And actually, in showing inpatient cases, we have split things between overnight and same day. And I suppose the reason for that is because, some hospitals, the majority of their inpatient cases are actually AMAU patients, which all come in and go home on the same day. They're very low cost, they're very low complexity, very low value. So by including them in overall inpatients, the overall inpatient value is taken down by the weighted average of the simplicity of those cases. So we've separated out inpatients into overnight. So you can see, what's your volumes, what's your CMI, what's your percentage split, and that has shown up some interesting things that kind of relate to admission policies. We've seen some interesting things with short stay maternity, how some hospitals have, thousands of day cases and thousands of same days, and other hospitals have virtually none. And look, I suppose we have to see, what arises of that, or what the perspectives are on that. And you can see then your CMI. Brian has said, this is the first time we've stopped the apples and oranges and come up with an admitted patient unit. And I've kind of come up with this example of if we can all remember back, I think 2001, we were jumping from one currency to another. So an Irish punt was worth 0.787564. A German Deutschmark was worth maybe 2.5 times that. So now, instead of having two different currencies, we now have a single currency. And I just said, so now we can, when the euro came along, we could see how much more expensive a Big Mac was in Ireland than in Germany, without having to open up our newspapers and work out what the exchange rate was. So, and now we can, if you think of hospitals, we can compare the cost of a fillet steak in Ireland to a schnitzel in Munich. So we can compare an ICU case now to a day case, because we have that common currency. And I suppose this I suppose one of the feedbacks when we ran the model was, I think the new CMIs people found quite jarring, because everyone was used to that rhythm of one being the average for all patients, and things moved in quite narrow bands around that. So this is a hospital. So under the old currency, their day cases were 0.82. So that's 0.82 compared to the national average of day cases. Their overnights were 1.77, and that's compared to the average overall for inpatients, and same days as 0.25. So now we can see under our new currency of admitted patient units that this hospital, their day cases, I suppose the Model 4 now is the overall average. So the average in Model 4 is 0.26 for day cases, 3.51 for overnights, and 0.39 for same day. So now this hospital can see that their day cases are slightly less complex, and this is a hospital that has, I think, the largest volumes of dialysis patients nationally, so that's not unexpected. Their overnights are considerably more complex than the Model 4 average, and that's because this is a national centre for complex treatment. And their same day, I'm not sure the volumes there, but their same days are more complex. So I think it gives a more granular breakdown and of complexity. And look, we're willing to help people kind of cross that gap. But I think as this becomes embedded, it will just become the same way as euros replace the Irish punt quite quickly. Again, this is just a table we put out in the report. So just look at the ABF cost versus the beds and look at the ABF cost per admitted patient weighted unit, and to compare that again against hospitals, against the other hospitals in the model and nationally. The ABF cost per bed, the weighted units per bed. I suppose one of the things that came out of these reports was, I don't think there was a single hospital where all of the traffic lights pointed in the same direction. You know, there was always a mixture of red traffic lights and green traffic lights, of things being above efficient or below efficient. And that's, you know, like, and stuff like cost per bed and admitted patient weighted units per bed, you know, that can be a factor of admission policy. You know, that issue about, you know, one maternity having thousands of day cases versus another versus one that doesn't admit those patients. So there, you know, this kind of, you know, there is further analysis possible on this. So looking at, you know, some of our major cost buckets, and again showing whether a hospital was above or behind that, you know, and I suppose that depends on the accurate costing of what goes into that cost bucket. How accurately is a hospital costing its medical pay to OPD, to externs, to ICU, or to theatre affects the amount of medical pay it has in the medical pay cost bucket. Same for nursing. The average length of stay review. I actually think this report is a goldmine. And you know, if we accept that a DRG is populated by patients who are clinically similar and who should, on average, be consuming similar amounts of resources, you know, that should also apply for length of stay. So this is just a summary of a very large Excel file that we sent with the hospitals out to the hospitals. So what we did is we compared what was the hospital length of stay versus the other hospitals in the average. I'm not sure, maybe from the back of the room. Now, the bottom example is probably the one I'll pick out here, which is B70B patients, which is stroke with intermediate complications. So the average in Model 3 is 18.6 days, but this hospital had an average for its 82 patients of 31.7 days. Now, we're not saying, you know, there could be extenuating factors for those patients, but just looking at those raw facts, that amounted to 1,070 bed days just within that DRG above the average. Now, interestingly, we did meet with a hospital, and their worst performing DRG, they were able to say to us, but look, we've had a patient in that DRG was discharged after 5 years, about 1,700 days. So that's the reason that DRG is out of whack. Now, you know, that's interesting to understand, and it's something we have to consider in terms of work in progress and how we fund patients that kind of span really long lengths of stay. But you know, look, what you know, other things we've noticed with this is, you know, for something that, you know, has predictable lengths of stay, like you know, maternity hospitals for, you know, birth DRGs like cesarean or, you know, normal delivery DRGs, we were able to see the hospitals that have the, you know, average length of stay that are, you know, half a day above or half a day below. So those are all bed days that are, you know, you could argue that they're lost to the system. And I think this report is an extremely valuable in terms of, you know, productivity and efficiency. I suppose just that file, I suppose if I was looking at that file and that was a single episode, I'd be thinking that patient looks pretty complex and they should be going into a significant DRG with major complications. So one of the other reports we've done is to look at, how a hospital's ABCD split, where there is a split, compares versus their peers, and I'd kind of regard this as, kind of ABF quality factor. So, and again, we were down here in Limerick, I don't know, 8 years ago, I think, and we were able to show Limerick that their coding of strokes was considerably behind their peer hospitals. And now the fact that we've, grouped hospitals into models, Model 4s, Model 3s, Model 2s, etc., I think, you have to consider other factors, whether it's a national centre for a particular type of care. But really for something like strokes, our perspective is that there should be some correlation between the ABCD split in one Model 4 versus another. So we've produced that data, and again, this is just a summary of a very detailed file that we've sent out to hospitals on 2022. And if you look at, well, what's the average value? Is that a value? Is there value lost or gained by by the coding in that DRG? But having said that, it absolutely essential to code within the guidelines. There's no target. There are natural variations between hospitals. And, we do have governance to make sure that hospitals are coding within the guidelines. One thing that came up was looking, we included discharge by day of the week. And I suppose what we noticed is that there is differences between the models. Model 2s, when we looked, there was only 11% of discharges at the weekend, compared to Model 4s where there was 15%. And, I think the public-only consultant contract, and, and again, it's kind of been a new story that, getting the consultants and senior decision makers in at the weekends, this is something we can monitor as a result of the data we have. And again, but you have to be intelligent using this, that any, I think maternity there, you can see the discharges are practically constant for 7 days a week. So maternity is a 7 days a week business. So any hospital that has maternity services as part of its services is going to look better under this analysis compared to peers. So that has to be factored in. The reports also included the explanations of our what were significant changes in the model list of the hospital, the model adjustment factors, and actually the model adjustment, it was actually Limerick that caused us looking at models. We're in a unique group here that there's only one Model 4 hospital. Everywhere else is either a Model 2 hospital and a specialist hospital. And we found that having the Model 4s, they were being disadvantaged by having them all in the same model. So that was the driver between splitting them out. An explanation of the admitted patient weighted unit, the updated DRG grouper, the significant changes we've had in terms of the DRGs and the co-payments. And Brian has said, look, we no longer need pediatric and tertiary referral hospital co-payments because of the grouping, and an explanation of the agency and the co-payments. So what's next? What we want to do is to do this using the 2023 data, and that should be issuing very soon. Because, I kind of think we had a meeting with the CFOs, which was a lively discussion earlier this year. And I think, in fairness, ABF had landed like a bomb, and there was no context to it. There was no signaling of the direction of travel. And, when you think of ABF, a lot of the inputs to ABF are now fixed. The money is spent. The cases are coded. The hype file is closed. We can look at, what is the direction of travel for some of those things. What is gross expenditure? How many cases have you changed year on year since 22? How have they translated into admitted patient weighted units in draft form? I think we can begin to socialize the direction of travel for ABF based on the 2023 data. Now, the inputs into the model are far from complete. You're working on your specialty costing returns. They are not final. So, your gross expenditure may have gone up, but whether or not that relates to ABF or block or translates into activity, we don't know that yet. Our relative values update annually. So each year, the benchmarking model produces a new set of weighted values. So the weighted units that you see before and after we run a model change for a particular period of activity. So those are the inputs that aren't final, but I think there is enough data to begin to understand the direction of travel. The deadlines, hype has closed. The specialty costing returns, we're expecting them back before the end of the month, with a final position of those returns by the 30th of September to allow us to run the model and have final budget adjustments by the 31st of October. PLC by the 31st of August, with a final position on those by the 30th of September. And look, I suppose, we do have hospitals feeding back about, the relativities. I don't like the price I'm being paid. I think I don't like the relativities. Well, unless you're actually contributing to those relativities by, submitting patient level costing and informing, and, some of the hospitals that have critiqued the relativities have been large drivers of those relativities. So we do need up-to-date PLC returns to drive those relativities and the results at transition by year end. Now we paused specialty costing audits during COVID necessarily, but letters have issued last week to the REOs and the hospital managers and the relevant contacts. So they are an essential part of ABF data quality processes. And really, I suppose the focus is on verifying the split between ABF and block. I suppose one thing, having spoken about how different admission policies affect different admission policies are one of a significant driver for us. If activity is coded, it translates into value, which then goes into the ABF model. So we will be actually looking for examples of, where is there ABF cases, where is there ABF value, where there don't appear to be beds. And I know there's a bed management system being worked on that will hopefully assist us in that. So there are supporting documents on our costing website. And I suppose having spoken about that for 2023, what we want to do is to continue that for 2024. Having said that, a lot of the inputs for 2023 are final and done. How can we affect some of the inputs that are happening in 2023? Can we identify, can average length of stay be fixed within a year? Can coding be improved within a year? Can we establish a better link between costs and activity and on costs and activity that is actually happening as we speak? And so if we can report and share on those in the acute hospital system, can those inputs be improved before the money is spent and the activity is final? And to institute the ABF benchmarking review group and actually examine those 2023 inputs ahead of them becoming part of the model, and to look at those inputs in the live year. So just final slide, Aoife. So doing okay. So community costing is now part of what we do. And the reason for that is to establish efficient use of resources and support business planning, and to have a single national approach. I suppose just in summary, I guess the bit we're missing in community has been the rich data that you supply to us in terms of the hype data, that there is no equivalent. There is a system out there called Inter-RAI that is being rolled out, but I think to some degree that has been slow and has been caught up with the recruitment issues. So we are looking to access resource utilization group data, a small subset, a small piece of that, to carry out a pilot costing study to assess the possible effect of patient resource intensity on costs. So hopefully we will have something to present on that for next year. I suppose just to close off, I think Stephen has said about how much productivity and savings are on the agenda now, and there is pressure on the system to justify the connection between costs and activity. And really, I just think that the data that you've been providing us for years is a key part of that. And I just think, your data will become very important and a goldmine for that. So, look, I think I look forward to working with you on that project of establishing productivity, because that is ultimately our core business. So thank you.